you're seeing is a question paper of Human Anatomy, Paper 2. And this question paper is from RUHS, Rajasthan University of Health Sciences. So this question paper is for MBBS students admitted in 2019 batch. But because this is of a supplementary examination, right? So this exam was held in July 2021. Okay, so this examination was of 3 hours of 100 marks question paper. It was divided into section A, which was of 50 marks. So there are 6 fill in the blanks and 4 MCQs in section A, and the rest is nearly a subjective portion. Then section B is also of 50 marks. There you have only the subjective part of questions. So you have to attempt this question paper into 2 separate copies. Okay, so my purpose here is to explain you these objective questions. Let's start with the fill in the blank questions. Question number A is, the thickest nerve of the human body is. It's so easy. Thickest nerve is sciatic nerve. Now let me explain you fast, just for your revision purpose, about the origin of sciatic nerves. For that you need to know about the lumbosacral plexus. So as you know, all the plexuses, cervical plexus, brachial, lumbar, lumbosacral, they are all being derived from the anterior primary rami. So let's presume what I'm drawing here is the anterior primary rami of L4, L5, S1, S2, S3, S4, S5. These are the anterior primary rami. Okay, now these anterior primary rami, they also split into ventral and dorsal divisions. So this is presumed to be ventral divisions I'll be drawing here, and the dorsal divisions I'll be drawing here. So from ventral division, you can presume what I'm drawing here is like this. This is the way the anterior primary rami splits and divides to form these 2 nerves. Here it is nerve 2 quadratus femoris, and here it is superior gluteal nerve. Then from L5 to S2, including S1, this is nerve 2 obturator internus, and this is inferior gluteal nerve. S2, S3, S4, here it is pudendal nerve, and here it is pelvic splanchnic nerve or nervi erigentis. This to be arising from the dorsal division or ventral division is a bit disputable. Now talking about divisions from the anterior rami of L4, L5, S1, S2, S3, all of them, they together form this nerve called tibial nerve. Then from the dorsal division of L4, L5, S1, S2, these form common peroneal nerve. Both these nerves, when they're covered by a common epineurium, then it's called sciatic nerve. So if you got the concept of sciatic nerve, there's one more nerve which arises from the dorsal division of S1 and dorsal division of S2. It also gets contributions from the ventral division of S2 and S3. Now again, these nerve fibers, when they enclose in a common epineurium, now this is called posterior cutaneous nerve of thigh. Now let's cover some important points. One thing I just told you is the thickest, also called as largest nerve in human body is sciatic nerve. So remember that sciatic nerve arises from the lumbosacral plexus. It has 2 components, tibial component and the common peroneal component, wrapped in a common epineurium. And when it emerges out from the greater sciatic foramen into the gluteal region, passing below to the piriformis, its thickness is around 2 centimeters. So when a nervous tissue is such thick, right, so it doesn't get good perfusion from the vessel surrounding. So there is especially an artery for this nerve, sciatic nerve, which is a branch from inferior gluteal artery. This is called artery to sciatic nerve. This accompanies the nerve for a short distance and then perforates and reaches and runs within the substance of sciatic nerve. So there's an artery running into the substance of sciatic nerve, and that is artery to sciatic nerve, which is a branch from inferior gluteal artery. So one thing now, you remember that the largest nerve in the human body, when you talk about largest, remember we're talking is about the bulk, the thickness, and that is sciatic nerve. Longest nerve in the human body is saphenous nerve. This can also be asked as longest cutaneous nerve in the human body is saphenous nerve. Then cutaneous nerve supplying the maximum area of skin of human body, or you can say the largest territory of the skin is innervated by which cutaneous nerve? So the answer will be posterior cutaneous nerve of thigh. This also is a branch from lumbosacral plexus. I have just taught you about this. Thickest cutaneous nerve in the human body is greater occipital nerve. Greater occipital nerve is a branch from the dorsal primary rami of the C2 spinal nerve. It supplies the skin on the nape of the neck up till the vertex. Then talking about typical spinal nerve. These are T3 to T6, also called as typical intercostal nerves. Thickest or the largest cranial nerve. The answer is trigeminal nerve. Longest cranial nerve, this is vagus. Cranial nerve with the longest intracranial course. Now this is trochlear nerve, fourth cranial nerve. Now the cranial nerve, which is more commonly subjected to stretch in case of increased intracranial tensions. Now this nerve is abducent nerve, sixth cranial nerve. So these were some important points about nerves, which can be asked like a single liner MCQ or a fill in the blanks in your future. Question number B is the normal site of fertilization of sperm and ovum in humans is. This is a vague question. In case if you write fallopian tubes, then also you are correct and you should get full marks. What I presume as a student of MBBS first year, you should write it as in the ampulla of fallopian tubes. There your answer will be more precise and more correct. You know that fallopian tubes are like this. They have these fimbriated ends, and this is how it is attached to the uterus. Now the purpose to tell you here is, here it is the intramural portion also. So the parts here of the fallopian tube, now this is the fimbria, which is attached to the free margin of this infundibulum. Then the dilated portion here is ampulla, and the part close to the uterus is isthmus. The portion coursing to the musculature of the uterus is intramural part. So the most common site for fertilization is the ampulla of the fallopian tubes. Now the next question is C. Approximate length of vas deferens is in centimeters. So remember it's approximate. So the answer will be 45 centimeters. Now for your help in future exams, let me cover up the important measurements in human body. Now, these are few important measurements which are generally asked in your exams. So let's talk about structures which are around 45 centimeter in length, which is equal to around 18 inches. Now such structures are vas deferens, as I just told you. But again, let me tell you, it's always an approximate or an average measurement. Just I'm telling is to make it convenient for you to learn. Otherwise, there's always a range. So vas deferens is around 30 to 45 centimeter in length. spinal cord. Again, remember plus minus 5 centimeter will be the range, both in male and females. Of course, in females it will be less. Then it's femur. Again, here also there will be sexual dimorphism, differences according to sex, according to age factor, and lot many factors. This is an average 45 centimeter or 18 inches is the average length of femur. I'm talking about structures which are 25 centimeters, which is equal to around 10 inches in length. This also has been asked many times. So remember, ureter is very commonly asked. Ureter, then you have esophagus, stomach, and duodenum. So all this in a sequence, like eso, stomach, and duodenum. Structure around 20 centimeter. This I'm telling you because this has also been asked, which will range around approximately 8 inches, and this actually has been asked that it is 20 centimeter. And what is that? It is phylum terminale. Remember, it's a modification or continuation of the pia mater covering the spinal cord from L1 lower border reaching up to the tip of the coccyx. So part of this phylum terminale lies within the dural sheath, because dural and arachnoid terminate at S2 vertebral level. So upper 3/4 of the phylum terminale lies embedded in the CSF within the dural sheath, right, in the lumbar cistern, and that's called phylum terminale internum. So upper 3/4, that is around 15 centimeter, while the lower 1/4, or the lower quarter, so the lower 1/4 of the phylum terminale which lies outside the dural sheath is called phylum terminale externum, and this will be 5 centimeter. Similarly, in case of ureter, remember, ureter is also divided into 5 inches and 5 inches. 5 inches is abdominal portion and 5 inches is pelvic portion. Now, one more structure that has been asked and can again be asked is around 10 centimeter, which is equal to around 4 inches. But again, it's a range, so the range lies between 10 to 13 centimeter, or between 4 and 5 inches. I have written it for your convenience to remember it as 10 centimeter, and this is fallopian tubes. This is like for undergraduate level to just memorize these measurements for important structures which are commonly asked in exams. So fallopian tubes around or more than 10 centimeters, which is 4 to 5 inches. One more structure which has also been asked once, and that is about vocal cords. So remember that vocal cords are 20 millimeter in length and 15 millimeter in length. This is very important because it has variations. So 20 millimeter will be in males or females? Guess it. Females have a higher pitch, right? So that means the vocal cords are smaller, shorter. That's why they have more elasticity and they have more high pitched sound. So 15 millimeters is the length of female vocal cords, and 20 millimeter is the length of male vocal cords. Now the next question is 1D. Left testicular vein drains into. So simple, the answer is left renal vein. You know, this pattern of drainage of the kidneys is IVC. You know, it's running on the right side of the spine, and here it is this right renal vein draining into this, and here it is this left renal vein. This is IVC. And the two renal veins, in case if they ask, is the vertebral level of these veins, the vertebral level here, L1, L2 junction, means lower border of L1, that's the transpyloric plane. Now talking about the drainage, so remember, because IVC is on the right side of the spine, so drainage from the right sided structures is directly into this IVC. These are the suprarenal glands. Now because IVC is towards the right side of the spine, so the right sided structures drain directly into the inferior vena cava. So remember that this Right suprarenal vein drains directly into the inferior vena cava. Similarly is the gonadal vein from the right side. This is the right gonadal vein, the right testicular vein, or the right ovarian vein that drains directly into the inferior vena cava. So this is right suprarenal vein, and this is right gonadal vein. This is right renal vein. Because the structures on the left side, they are away from this IVC, and in between you have is the spine. So as to take a shortcut, the left sided structures, they take a shortcut and they drain into the left renal vein. So this is the left gonadal vein, or the left testicular or left ovarian vein. Similarly, the left suprarenal vein that also drains into this left renal vein. Now, question number 1E, that is, center of the portal lobule is indicated by what structure? So the answer here is the portal triad. You must be knowing the histology of liver, and there you must have seen such hexagonal structures. If you remember, now these hexagonal structures were actually the hepatic lobules, like this. So in these hepatic lobules, there is a lamellar arrangement of the hepatocytes radiating out from the center. Now the center is formed by the central vein of the hepatic lobules. And from here, there are hepatocytes arranged which are radiating out like this. And at the corners of these hexagons, you find is the branches of hepatic artery, canalicular branches, and you also find the branches of portal vein. You will also find bile canaliculi. These bile canaliculi, they collect the bile and they drain it out through the right and left hepatic ducts. So now what you have seen is that this structure is called hepatic lobule, and the center of hepatic lobule is the central vein of the lobule. And these structures you're seeing, these are called portal triads. Now if you connect the three central veins like this much portion you are seeing is called the portal lobule. So here in the center of a portal lobule, what you are finding, it is called the portal triad. So the answer in your fill in the blank will be a portal triad. This is portal triad. One more thing, if they ask sometime that what is hepatic acinus? Now, hepatic acinus is like this. It's like a diamond shaped thing with the two portal triads on the two sides and the two central veins on the two sides. This is called hepatic acinus. So you got the shape of the three different structures which are commonly asked in your exams. This hepatic lobule, H for hepatic, H for hexagon. Remember this. Portal lobule is triangular and the center is formed by portal triad, and hepatic acinus is a diamond shaped thing connecting the two portal triads on the two adjacent sides of the hexagon and connecting the two central veins. It's a diamond shaped acinus. Now the next question here is 1F. The ascent of horseshoe kidney is arrested by. So the answer here is inferior mesenteric artery. It's so easy because a horseshoe shaped kidney, mostly it is joined at the lower ends like this. It joins like this, and this has to ascend up. So there's an abdominal aorta in between. The first unpaired artery in between will be inferior mesenteric artery, superior mesenteric artery, and this is celiac trunk. So during the ascent of this horseshoe shaped kidney, what hinders its ascent up is inferior mesenteric artery. Now we'll be solving these MCQs. There are only 4 MCQs. Question number 2, 1. Which of the following is a typical intercostal nerve? So the answer will be C, third one. I already told you that the typical intercostal nerves are T3 to T6. Remember this. Next question is, which of the following is not attached to fibula? Tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius. No doubts, all the four muscles here you're seeing, they are all the muscles of the front of leg, the extensor compartment of the leg. Out of these four, three muscles take origin from fibula and only one that takes origin from tibia. I'm trying to draw this for you, the front of leg. Hope you can understand what I'm drawing. This is tibia and here it is fibula, like this. And here you know what is this joint forming? Inferior-tibiofibular joint is a syndesmosis. And the interosseous membrane here, it's running down like this, downwards and laterally from tibia to fibula. I'm going to focus upon the muscles here. Remember this bony landmark? This is tibial tuberosity. And what is this? This is called the shin. The anterior prominent subcutaneous border of the tibia is shin. And no doubt, fibula also has this anterior border here like this. To this anterior border of the fibula, there is this anterior intermuscular septum attached. And the deep fascia itself gets attached to the shin or the anterior border. So that the anteromedial surface, this surface of tibia, becomes subcutaneous. Now talking about the muscles, this muscle here you're seeing is the only muscle that arises in the front of leg from tibia, and this muscle is tibialis anterior. Now the other three muscles, it's like this. Remember the toothbrush-like structure. The toothbrush-like structure means in the upper 1/3, this muscle takes origin from fibula, and of course all the muscles you're seeing in the front of leg, they do also take origin from the adjacent surface of the interosseous membrane. So this muscle here is extensor digitorum longus. Now in the middle 1/3 of the fibula, you find is another muscle that takes origin here, and this muscle here is extensor hallucis longus. So in the middle 1/3, fibula provides origin to both extensor hallucis longus as well as extensor digitorum longus. In the lower 1/3, there is only one muscle that takes origin from fibula, and this muscle here is peroneus tertius. Okay, so it's easy. Remember this. Only one muscle that takes origin in the front of leg from tibia is tibialis anterior, and the rest three muscles that take origin from fibula. So the question was, which of the following muscle is not attached to fibula? Of course, your answer here will be tibialis anterior. I just told you about this muscle. Okay, now the third question is, pacemaker of ureteric peristalsis is located in minor calycis, major calycis, pelvis, or pelvi-ureteric junction. I guess if most of you may not be knowing it, then you could have easily guessed it, because there's hardly much spaces between minor and major calyces, and actually this is like within this renal sinus, where you need not have much of this peristaltic activity. Peristalsis actually starts from the renal pelvis down to the ureters. But this has been worked upon by various scientists, various research scholars, and has been published in international journals. Earlier it was considered that the renal pelvis is the site, or at the upper limit or the proximal portion of the renal pelvis, or pelvic-calyceal junction was supposed to be the site of the pacemaker cells. By the way, let me tell you, the pacemaker cells in the renal pelvis, let me write it, pacemaker cells in the peristalsis of this ureter, you have atypical smooth muscle cells. Remember, like in SA node and AV node of the heart, that also are the specialized cardiac muscle cells with a sort of functional syncytium. Here also you have is a functional syncytium and multiple nuclei you find in the Purkinje cells. If you remember this conducting system of the heart, you will find that this is a modified form of myocardium which conducts the impulses from SAAV and then right and left bundle and through the Purkinje fibers to the ventricles. Here also you have atypical smooth cells which are progenitors of these impulses, and that is through the action potential created. And there are also special cells called interstitial cells of Kajal. Now these cells are also present in the GIT, because GIT also there is peristalsis. So in GIT it's also presumed that these interstitial cells of Kajal have a role in conducting those peristaltic waves. Such cells are also being found out in this renal pelvis in the proximal portion, or some authors have written it like in the upper portion of the ureters at the pelvic ureteric junction. So this question I think is still remains a dispute. I have found answers by various authors writing it as in the calyceal system. Some have written in the upper portion of the pelvis. Some have written in the proximal or the upper end of the pelvic ureteric junction. So according to me, I think the better answer here should be pelvic ureteric junction. You could mark this. In fact, the exact answer lies in the mind of the examiner who framed this question. So pelvic ureteric junction means at the proximal end of this pelvis towards the pelvic ureteric junction, there you find these pacemaker cells. But let me tell you, there is even distributed up till the calyces, major and minor calyces region. Also, you find there's been these specialized cells have been found. Anyways, if you have to take one, I think you can take this pelvic ureteric junction. Now the next question, the last question here is the hypospadiasis occurs due to undescended testis, ectopic testis, non-fusion of the genital folds, incomplete fusion of the genital folds. Now hypospadiasis is the opening of the terminal meatus of the urethra. Instead of opening at the glans, the terminal end, it opens on the undersurface either at the level of the corona or the lower portion of the glans or undersurface of the shaft or at the root of the shaft on the undersurface or even up to the scrotum, in between the scrotum. So that all depends because of this development of urethra. If you study this urethra actually is formed by the two genital folds which fuse in a zipper like fashion from proximal to distal. So if this fusion remains incomplete, the terminal meatus might end up opening on the undersurface of the shaft of penis or somewhere in between, and that's called hypospadiasis. And the region of the penis beyond to this terminal opening on the undersurface of the penis, the terminal portion of the penis, which has no role now in the ejaculatory or the urinatory pathway because the urethra has already opened on the undersurface of the shaft. So that portion is called chordae. So the answer here will be incomplete fusion of the genital folds. Now the next question here is subjective type questions, a clinical based question. A 48-year-old man felt uneasiness in the left side of his chest. He felt better after resting. When he consulted his doctor, he was advised coronary angiogram. What is the origin of the coronary arteries? Of course, aortic sinuses. The anti-aortic sinus provides origin to the right coronary, and the left posterior aortic sinus provides origin to the left coronary arteries just at the beginning of this ascending aorta. This is what is the purpose of the coronary angiogram. Of course, to see the patency of the coronary vessels. What is the difference between angina pectoralis and myocardial infarction? So angina is actually the pain because of those narrowing of the coronary vessels. Now narrowing of the coronary vessels can have several reasons. One of them is spasmodic contractile waves in this coronary vessels, spasmodic contraction, and that's called prismatic angina. or maybe because of the thickening of the wall of the arteries, arteriosclerosis. And that's why that insufficiency to perfuse the heart musculature causes pain, sharp pain. But then angina doesn't leaves a irreversible response. It can even be cured. It can even be reversed by immediate action. However, myocardial infarction is also commonly called heart attack or heart failure. Now, this myocardial infarction is when there is loss of blood supply to a particular region of myocardium because of the occlusion of the coronary arteries. And there it is the atherosclerosis of the coronary vessels which is the main cause. The plaque blocks the vessels and thereby limiting or completely blocking the perfusion of the myocardium. So that's the difference between angina pectoralis and myocardial infarction. Give comments on coronary bypass. No, you must have heard this CABG, coronary artery bypass grafting. This is mainly the left internal mammary artery, IMA, the left internal mammary artery, which is commonly used for coronary artery bypass surgeries. Right briefly on the left coronary, of course, you'll have to describe this coronary artery in detail right from its origin, although it's, left coronary artery is a larger artery than the right coronary. But left coronary artery itself is shorter in length. It soon gives out its anterior interventricular branch, also called LAD, that is left anterior descending artery. So after giving out its anterior interventricular branch, then it winds around into the left side of the AV sulcus, continuing as the circumflex coronary artery, and then terminally anastomosing. It also gives an oblique branch, marginal branches, and other branches, and ultimately reaches to anastomose with the right coronary at the crux of the heart. Sometimes it might also give the posterior interventricular branch. Write short note on any 5 boundaries and subdivisions of the medial sternum. Very easy. Major openings in the thoracoabdominal diaphragm. I hope you know this. Aortic opening T12. Esophageal opening T10. IVC opening is T8, the highest opening. You should mention all the rest of the structures passing through these openings. I'm not going to discuss all this here right now. Now, bare area of the liver is also important. The areas which is not covered by the peritoneum. Sternal angle, there are around 13 structural changes that are happening here at the level of sternal angle, and that is the level of T4, T5. Enumerate ligaments of the knee joint. Again, this is important. There are around 13 ligaments of the knee joint. You will have to enumerate all of them. Differentiate between male and female. Sacrum. So sacral index is very important here. Remember, sacral index will be more in female and less in males. That is the diameter of the sacrum at the ella, at the level of the ella, and the vertical thing. Explain briefly any threes. Vermiform appendix, you should mention this. The most common position of an appendix is retrocecal. Thoracic duct, of course, it's very important. Its relations in posterior and superior mediastinum is also very important. Microanatomy of spleen, remember PALS, periarteriolar lymphatic sheaths. The red pulp, white pulp, open and closed circulatory system here. Everything you need to know about the spleen. The central arteriole within the white pulp. Femoral canal is very important, related to femoral hernia. The medial compartment of femoral sheath. Now, section B, describe uterus in the following headings. These are parts and relations of the uterus, then supports of the uterus, and applied anatomy. A long question. Write short notes on any 5 saphenous opening, also called the cribriform opening. With this great saphenous dips inside and opens into this femoral vein. But there are branches of the femoral artery also emerging out through this. SA node has to be understood in detail. You have to mention this. I just told you about the pacemaker activity happening here, and it is located at the upper end of this sulcus terminalis near the opening of superior vena cava. Celiac trunk and its branches, very important. Remember the vertebral level here, it is T12L1 junction or the lower border of T12, right? And of course, the left gastric, splenic, common hepatic branches. Boundaries of the femoral triangle, super important questions, covering of the spermatic cord, external cremasteric, internal cremasteric, right? And the cremasteric fascia, all you need to know. Then Trendelenburg test, of course, this is a vague question because they haven't mentioned. Trendelenburg test is also for the abductor mechanism of thigh. That means injury to superior gluteal nerve will lead to paralysis of gluteus medius, minimus and tensor fascial artery. And because of that, you have a test to check it out, and that's called Trendelenburg's test. Similarly, Trendelenburg test is also used to check the competency of superficial and perforator veins of leg. So they haven't mentioned actually Trendelenburg test. They're trying to ask regarding what. So I think you should write in any of the two tests. You should get marks. Explain briefly any four. Trachea, you have to mention about the trachea. Histology of duodenum, important hai. Brunner's gland, don't forget. Locking and unlocking of the knee joint, of course, locking is by, yes, vastus medialis. Unlocking by popliteus. Lesser sac, which lies behind the stomach, behind the lesser omentum. And extrahepatic biliary apparatus has to be written in detail.